So now that we've gone through airway, breathing, circulation, what we want to do is what they're calling a rapid scan. Um, you take about 60 to 90 seconds to basically go head to toe to make sure that you're not missing anything that's a life threat. Um, I've always called this a rapid trauma assessment, and literally 90 seconds tops in order to go top to bottom. If you find injuries that are not life-threatening, make note of it, but keep moving. You're not actually going to stop for anything that's not life-threatening. After you perform that rapid scan, you're going to go ahead and determine the priority of the patient and how you want to transport them. Your primary assessment is going to tell you if the patient is sick, not sick, or could be sick. If they're sick or have the potential to move to being very critical, they need to be transported rapidly. Otherwise, you can stay on scene and do a little more assessment. So we tend to call these load and go patients or stay and play patients. High priority patients are those that are unresponsive, have a very poor general impression, they're having trouble breathing, they have uncontrolled bleeding, or you have to put a tourniquet on them to control the bleeding. They need to see a surgeon. They're responsive, but they're unable to follow commands. They have severe chest pain, pale skin or other signs of poor perfusion, complicated childbirth, or severe pain that you can't control in any part of the body. As an EMT, you cannot administer pain meds. That has to be ALS service. So if you're dealing with somebody that's got severe pain, you've got to pass them on. The golden hour, or now known as the golden period, is the time from when the injury occurred until they get definitive care. Typically, when we get them to the hospital, sometimes the hospital isn't able to appropriately manage them, and so they end up having to send them on, which just delays their treatment even more. For us, we don't worry so much about the golden hour or the golden period. Really, what we're trying to do is assess, stabilize, package, and begin transport to the appropriate facility within 10 minutes after arrival on scene. We call this the platinum 10 minutes. So we should be transporting our patients within 10. You'll notice on your testing sheets that you do have to transport the patient or state that you're transporting, and there is a time limit on that. So make sure that you're paying attention to that. Here's how the golden hour is kind of broken down. So the discovery of the incident activation EMS is expected to take approximately 20 minutes. Once we arrive on scene, we should have the patient in the back of the rig and transporting within 10 minutes. Does that mean that we have all of our treatments, everything stabilized, all of our assessments done? No, some of that stuff can be done while you're transporting, and the more critical the patient is, the faster you want to transport them. And then once you get through that 10 minutes of getting them going, the next 30 minutes should be our transport and then the initial hospital stabilization to try and give that patient the best chance for a positive outcome. Transport decisions should be made because of the patient's condition, their availability of advanced care, distance of the transport. If you have to go a long distance, you may initiate transport earlier in a non-critical patient just because you do have to travel so far. And then local protocols. In most of our systems, we know exactly where we're taking our patients. Here in Sioux Falls, we have 2 hospitals, so they're going to one of the 2. A lot of it's going to be patient preference. But some bigger systems have several different hospitals that they can go to. Each of the hospitals has a different specialty or capability, and so you may have to take your patient somewhere because somebody there has that history taking. So this is the next section of doing a patient assessment. So history is going to give you more insight into the patient's chief complaint and their signs and symptoms. This also includes their demographic information. So you need the date of the incident, the patient's age, gender, race, past medical history, and then current health status. For past medical history, what we're more worried about is significant past medical history. I don't really care if they stubbed their toe 10 years ago, or if they're 80 and they had their tonsils out when they were 15. I'm really not so worried about that. I'm worried more about what is going on with what's currently happening. So you want to investigate the chief complaint. Make any introductions that you need to in order to make or help the patient feel comfortable. Make sure that you obtain permission to treat. Ask few simple, direct questions just to build trust between you and your patient so that they will actually tell you things. Refer to the patient as Mr., Ms., or Mrs. using their last name unless they are okay with being called by their first name, and you can just ask them if they're fine with that. Make sure that you ask open-ended questions, because then you're going to get a lot more information than you would if you just asked for yes, no, or single answer questions. Make sure you use eye contact and repeat statements intermittently just to assure the patient that you're listening. You don't need to repeat back every single thing that they say, because then they're going to be like, wait, time out. This person has no idea what's going on. It's more so just to clarify if you need it, but just to give the patient a sense that you're actually listening to what they have to say. If the patient's unresponsive, you may be able to gather some clues about the scene or from about the scene. If they have pill bottles, see if they could possibly be the patients and what they're taking. The types of medications that they're taking will give you clues as to the medical history that they have and what's going on with them. You can certainly ask any family members that are present. Doesn't necessarily mean they're going to have answers for you, but definitely worth a shot. A person who may have witnessed the situation can give you some more history. Bystanders, medical alert jewelry. Every once in a while, I'll look for this. I would say that it's truly not my priority. If I get through A, B, and C, patient's doing pretty well, yeah, I'll probably check the wrists and around for a medical alert bracelet. Other than that, I'm not really looking for much. I did have some people approach me a couple years ago about medical alert tattoos. Really? I'm not going to be checking for tattoos. I'm not going to get in somebody's phone and look through there in case of emergencies. I don't want that kind of liability on me. If the police would like to do that, they're more than welcome, but I am not going to go snooping around in somebody's phone. You also want to see if you have any other documentation. Oftentimes the elderly will have a written out med list of what they take, why they take it, how much they take it, and when they take it, because it's really hard to keep all their medications straight, so they'll have it actually written out. Ask them if they have a med list that can help you. When we're using OPQRST, that will help you assess the symptoms of what's going on. Even if they're not having pain, you can still use a modified OPQRST. Just make it make sense, basically. So going through them individually, O is the onset. So when did this start? What were you doing when it started? Provocation or palliation. Provocation is, does anything make it worse? Palliation is, does anything make it better? And don't ask them together. Does anything make it better or worse? Ask them separately, because you're going to get much better answers about that. The quality is, What does it feel like? Can you describe it to me? The next is region or radiation. So where do you feel this symptom? Or does it move anywhere? Severity on a scale of 0 to 10, 10 being the worst pain that you've ever felt in your life. You need to give them that reference. How would you rate your pain, your shortness of breath right now? And then timing. Has what you're experiencing been constant, or does it kind of come and go? Did it come on gradually? Did it come on suddenly? And you're saying it's at this severity now. Did it start at that severity, or did it build up to it? And then you want to identify any pertinent negatives. Pertinent negatives are findings that warrant no care or intervention. They're often helpful in identifying a patient's problem and choosing an appropriate treatment. A lot of what we see has kind of those classic signs. For example, if somebody is having a heart attack, we would expect them to have potential of chest pain, shortness of breath, nausea, vomiting, lightheadedness. They'll be extremely diaphoretic or sweaty. And then if they don't, so if we're talking to somebody with chest pain and they're like, yeah, but you know what, I'm not sweaty, my blood pressure's good, my pain is probably about a 3, we can kind of deduce that they are not probably having a massive heart attack. Doesn't cross it off completely, but it makes it less likely. So those things would be pertinent negatives. Sample history is the other very important mnemonic that we use. This is going to be given to pretty much every patient. This is how you're going to obtain more information about your signs and symptoms, and then you also will get information kind of on their past medical history some more. So S is for your signs and symptoms. What signs and symptoms occurred at the onset of this incident, or what other things are going on? And this is where I like to do that quick verbal head to toe. I start at the top of the head. Are you having any headache, any lightheadedness, blurred or double vision? Are you having a cough? Are you having any chest pain, shortness of breath, any abdominal pain, nausea, vomiting? Are you having any numbness or tingling in your hands or feet? Are you feeling weak at all? And I just run through kind of all of the major signs and symptoms of what a patient could be experiencing. That also helps me check off all my pertinent positives and negatives. The next would be allergies. And this isn't just to medication. I want to know about your allergies to medication, to food, or if there's any other substance that you have an allergy to, especially like gloves or nitrile. Medications, what medication are prescribed to you. I want to know about prescription. I want to know about over-the-counter. And then have you taken anything to deal with this issue? Pertinent past medical history. Do you have any history, medical, surgical trauma that could potentially be related to this incident? Last oral intake. When did you last eat or drink anything? And then if it was relatively recent, say, well, how much did you have? You know, if they have to go directly into surgery, they're going to want to know what was the last time they ate and what was it. Events leading up to the injury or illness, what were the key events that led up to this happening? Just see if there's anything significant. And we'll continue on in the next recording.